He's not breathing.
Wouldn't you agree, Doctor?
Incoming!
In here, Dr. Connors.
Hi, I'm Annie Onishi.
Annie Onishi is a surgery resident.
No. I graduated residency. I'm a fellow in trauma surgery and critical care now. You asked for it, I'm back breaking down more clips from film and TV. Roadside liver surgery, the good doctor.
Here's your liver. I'm gonna need you to sign for it.
How long ago did you take it out?
3 hours?
We just lost 3 hours.
Technically 3 hours and 5 minutes. True clock's on the cooler.
So once an organ has been removed from a donor, that starts the clock for what's called the cold ischemic time. That is the amount of time that the organ is not actively receiving blood flow from the original patient and then from the recipient.
What about a police escort?
You my doctors?
An MD does actually personally deliver that cooler. You get to ride on an airplane sometimes, get to ride in the back of an ambulance, lights and sirens. It can be pretty exciting.
I don't know what you're looking for, Sean.
Yes, I can feel it. It's firmer.
I don't know what that means.
There must be a clot, but there isn't a clot. The scans show no clot.
There's no way you would be able to detect a clot or a thrombus inside the liver. That's just not. Unless you had ultrasound vision at the tips of your fingers, you wouldn't be able to do that.
We have to immediately remove the clot and flush the left lobe to protect it from the ice bath.
So you don't need to protect the liver from the ice bath. I'm not sure what he's talking about.
Okay, we need to stop the car.
Here?
Yes, we need to operate right here, right now.
So great, they Googled quinode segments. That's like super cutting edge, super accurate. So the quinode segments are how we anatomically divide the liver based on its blood supply and its biliary drainage. So there are segments 1 through 8. This is correctly labeled. It's missing segment 4A and 4B, but other than that, that's pretty good. This is also not what a liver looks like. So when a liver is procured from a donor, it actually comes with a bunch of stuff attached to it. So it comes with the big portal triad attached to it. That has basically the business end of the liver, how the liver drains. It comes with a little piece of intestine attached to it still, bunch of blood vessels in the back. We bring more than we're gonna need, basically. It does not look like that.
This is better than having a baby in my car.
Do not put that liver into me. Subcutaneous infestation, evolution.
Get this guy out of me!
It's gonna be okay, Harry. Cut him open. Let's get this thing.
Cut me open! There goes your Christmas gift, Judas!
All right, it's moving down his leg.
I would put a tourniquet on the leg and trap it and go after it there. That's what I would do.
Wait! No. It's going the other way. How are you going in?
Rectally.
Personally, I don't think I could get to this rectally. It does look pretty subcutaneous.
I'll get the lubricant.
There's no time for lubricant.
There's always time for lubricant!
Agree. There's always time for lubricant.
Don't clench. Don't clench.
So as an expert in rectal foreign body surgery, telling the patient not to clench is not gonna work. You really have to give these people a lot of sedation and get them pretty much totally asleep if you're gonna go up there and fish something out. He looks like he's in a ton of pain and obviously very uncomfortable. There's no chance of getting anything out.
Oh, it's over. It's over.
I've never personally seen a bug like that crawl from the leg into the colon.
What do we do?
The only bugs I've ever encountered have been in Kenya. There's an intestinal parasite called ascariasis. It's a series of tapeworms that end up living inside the intestinal tract and actually cause obstructions.
Don't you ever do that again!
Cricothyroidotomy from Anaconda.
There's something in the mouth.
Damn, what's that?
Well, he's still not breathing. What are we gonna do?
Quickly.
What's that for?
That's not exactly how you do that. A cricothyroidotomy is an emergency procedure that is performed when a patient has their airway that cannot be intubated from their mouth. So it looks to me like the indication here for cric is that this patient has some sort of wasp in his upper airway, so maybe there's some swelling in the airway. So typically a breathing tube will go into the mouth, into the trachea, and then we can connect that tube to a breathing machine so the patient can still breathe. In an emergency situation like this, yeah, I would probably just use my knife, get down to the cricothyroid membrane, and yes, enter sharply like he did there. I'm not sure what kind of tube that is, but it looks like a reasonably sized tube. But they would need to start ventilating right away. It doesn't work if you just stick it in there. You have to breathe for the person.
It's gonna be all right.
Chaotic emergency, Grey's Anatomy.
How are his vitals?
Bad. We've got no airway. I can't cric.
The doctor here says that she can't cric, and I don't know why. You can almost always cric.
He's got sub-Q emphysema.
Okay, stop. And this thing that she says, sub-Q emphysema, what that refers to is that child has air in the skin and in soft tissues on the chest. That's usually a sign that something really bad has happened to this kid. He probably needs an emergency chest tube, and he certainly needs his airway controlled somehow.
All right, I need an ET tube. Orange drawer. Orange drawer.
I knew that. No chest sounds on the right. I throw in a chest tube.
Wait a second, does anybody actually have chest tubes?
So clearly in this chaos, the nurses are not here, so the doctors are trying to do the job of both the doctors and the nurses, and this is what would happen.
I'm trying to set up this saline drip and I can't get this thing to stop beeping. Anyone?
So that's 100% accurate. So when doctors like me try to set up IV pumps, which is normally the nurse's job, usually we can't figure it out. Usually there's bubbles, there's beeping, there's alarms, nothing works, and a nurse usually has to come and rescue me.
IV drip rate is different for kids depending on the size. So anybody have a calculator?
Braslo tape says he's 30 kilos.
That Braslo tape, that's a real thing. So when a child comes in, it is a tape that you literally measure their body length with, and it will give you the best estimate for how much that kid weighs.
Braslo tape says he's 30 kilos. Standard concentration of dopamine is 1600 mics per cc. So 5 times 30 is 150 times 60 minutes an hour is 9,000. Divide that by 1600. Infusion rate is 5.625 cc's per hour. So
that's the kind of math that nurses do in their heads all the time, or they have memorized from giving these medications so frequently.
Oh, I feel like an idiot.
Brain transplant in Get Out. So in Get Out, they perform a series of really barbaric and racially driven brain transplants. Luckily, in my opinion, brain transplant is not a thing and probably won't ever be a thing. Rookie mistake, you're all sterile, you're all scrubbed in, and then you touch your mask. Start over. So technically, those glasses don't count as eye protection. He's a psychopath, but he should really know more about sterile technique. In real brain surgery, you don't actually remove the skull cap. You make sort of a curvilinear incision along the plane of what part of the skull you're gonna remove. So this is clearly Dr. Armitage's special torture brain surgery tray.
Wait, I am so confused.
I don't really recognize any of those instruments. I think the instrument second from the bottom looks a little bit like something called a rongeur, which is how you remove bone fragments from things. I see some suture scissors up next. Honestly, the thing on the left looks like a speculum for lady parts, but I'm not 100% sure.
I mean, I told you not to go in that house.
Directing your own surgery, Ronan.
Easy. I've done this many times before. We're here. Just cut up there. Just a little cut.
The operating surgeon here is using an 11 blade. That's typically not really used on skin in this manner. Typically, to make the first incision on skin, you use a 15 blade or a 10 blade.
Take the clamp.
This is a sponge stick. You see a ton of sponge sticks in medical dramas. It's unbelievable.
12 inches blood clamp.
You see where the blood's coming?
This is not how you use a sponge stick. A sponge stick is typically used deep in the body. It's a piece of gauze wrapped around what's called a ring forceps.
I'm sorry.
It's used to very gently retract very delicate structures that are deep and in the way. It's not used to blot.
Now, open it up, spread it, spread it.
Robert De Niro is describing spread, 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 which means actually inserting the tips of that instrument and spreading tissue so you can make a cavity bigger. That is a maneuver that we use in surgery very commonly if we need to get access to a certain place.
If you don't mind, I'm gonna pass out.
Dropping someone off at the ER and then leaving. Hustlers.
Please help! This is my husband!
This is actually a thing. We sort of tongue-in-cheek refer to this as the homie drop. Usually it's because either they happen to be right by the hospital when they got hurt, or somebody's too scared to call the cops or call EMS. Usually we're just grateful that they brought the patient to medical attention so we can help them. Heart surgery from Crank 2.
Ooh.
That is not what the human heart looks like. First of all, it doesn't continue beating once it's all disconnected. Without sounding too creepy, yes, we do comment on people's insides. So as silly as that looks, that does actually exist in real life. It's called a total artificial heart. It's usually used as a bridge to a transplant for a patient who has something very, very wrong with the actual muscle of their heart.
Wow!
This is definitely some back alley heart surgery. I really would not recommend going to these doctors.
That's not so bad.
Jack's appendectomy, lost. So you do actually flick the needle like that. That's to get the little air bubbles out so you don't inject air into the patient.
You know, Jack, they found some chloroform at the medical station. I could knock you out.
No, managed with lidocaine.
Lidocaine is a local anesthetic that's used to numb the area. It's what you commonly might get in your gums at the dentist. That is a massive incision for an appy. That is huge, totally unnecessary. Appy is short for appendectomy, which is the surgical operation to remove the appendix.
Spreader?
I think that she's probably asking for what's called a self-retaining retractor. That's a little skin retractor that would stay open by itself, freeing your hands. Oh, there we go. Look, that's actually what's called a finichetto retractor, not typically used on the abdomen.
No, hey! No, I want to be unconscious.
You don't want to be out of control.
Here, damn it, Bernard, knock him out!
I'm sorry, Jack, but I agree.
Well, he's just being loud and fidgety. I would want him knocked out too. But there's a lot of reasons we put patients under general anesthesia for surgery. Obviously, one is comfort. The other is total muscle relaxation. So we actually give you a little bit of a paralytic so your muscles completely relax, and that actually makes incisions on the abdominal wall much easier.
Wouldn't you rather be dreaming about something nice back home?
Eating human brain from Hannibal.
See, the brain itself feels no pain, Clarice, if that concerns you.
So it is actually true, the brain itself has no pain fibers. So once the patient has been sedated and the craniectomy part has been performed, they don't actually need to numb the brain in any way.
Now here's the sac that contains the brain.
So here, this little membrane Dr. Lecter is removing is something called the dura. It's not really that stretchy or kind of shiny like that or rippable like that, but that is an actual layer that protects the brain between the brain tissue itself and the skull. And if you look at this diagram here, you can see all the different layers in the head. So you have the scalp, the skull, then there's a potential space with the different layers of dura, followed finally by the brain tissue actually below all of that.
That smells great.
I personally prefer mine with a little more garlic than that, but I'm sure this is fine. Though I'm not a brain surgeon, I do know that in some neurosurgical procedures, the patient is actually wide awake, so that fine, elegant tasks such as speech or fine motor movement can continue to be tested while the surgeon is operating on that particular area of the brain. So that way the surgeon knows this is the area that's controlling this for this patient. We shouldn't cut that, we shouldn't touch that. Self-surgery in Wolverine.
I gotta get that thing out of me.
No, listen to me, Logan!
First of all, I wish my scalpel was attached to my hand like that. That'd be pretty cool. That looks like pretty pure CGI to me. It doesn't look like real X-ray.
No, stop! No, listen to me, please! No! Stop! Listen to me!
There are some operations that we do use active X-ray so we can monitor certain parts of the body while we operate on them.
Keep going.
So our orthopedic colleagues always use something called the C-arm, which is a dynamic movable X-ray to take pictures of the bones as they're getting fixed. Same thing with vascular surgeons. They very commonly use X-ray to take pictures of the blood vessels that they're operating on and to fix those blood vessels. So the use of X-ray in and of itself during surgery is very common. The surgical checklist, ER.
Don't remember being asked if Dr. Benton could scrub in for this.
And this is an example of how a surgeon comes in with his hands sterile and somebody else helps him get dressed.
Put him under, let's do this.
Whoa, whoa. What about the checklist?
Excuse me?
Safe surgery checklist?
The safe surgery checklist is a real thing that's practiced every day in every operating room in this country.
I've had 10 cases a day, doctor.
It'll only take a minute.
1 minute.
John Cotter here for a right cadaveric renal allograft. Does the patient have a known allergy?
No.
Does anesthesia anticipate a difficult airway?
No.
Is the risk of bleeding greater than 500 cc's?
So that's a great representation of a surgical timeout. That's really thorough. It goes through all the major important things.
Any nursing concerns?
We don't have any reperfusion solution.
We won't be needing it.
I'll have some sent up.
They said they didn't have enough perfusion solution in the room, so the nurse went to go get it. And that's gonna save them some trouble later on in the operation, so people aren't rushing around trying to get what's needed.
I think that this is an excellent teaching opportunity, Mel.
We take this practice from airline safety. So before an airplane takes off, the pilot, the co-pilot, and the air traffic controller go through a checklist where they check every single system on the airplane, make sure everything things in working order before the plane takes off. A surgical checklist is the same thing. We make sure that we have identified the proper patient, that we're doing the correct operation, that we have all the equipment we could possibly need, and it really is meant to reduce medical errors and surgical errors.
Now let's just take our time and introduce the room.
Sheila Lane, scrub nurse.
Paula Cheney, circulating nurse.
Kay Schumacher, anesthesiologist.
Randall Okerman, chief surgical resident. Ethan Dean, surgical intern.
So that's actually a great representation of who all is in an operating room. You had the attending, you had 2 assistants, the resident and the intern, those 2 nurses there, the circulator and the scrub tech, as well as the anesthesiologist. This is actually very accurate.
Were any antibiotics given in the last 60 minutes?
Just starting them now.
10 blade.
Okay, hold on. If you run the antibiotics prior to incision, you cut the risk of infection by half.
Dr. Benton, you're a guest here, and I don't like guests. As a friend of the patient, you're welcome to sit, observe, and shut up. 10 blade.
In real life, surgeons are definitely not that impatient. They will absolutely wait for the antibiotic to go in because they don't want the patient to get an infection.
Any concerns from the surgical team?
Only that you're wasting my time.
So it seems like this surgeon who's about to do this operation is sort of anti-checklist. That's really a no-go these days. So we always do a timeout no matter what. Well, that is a lawsuit waiting to happen. Impersonating a nurse, The Dark Knight.
Hi.
So nurses do wear nursing uniforms. That's a little outdated, a little old school. Most of them are just regular scrub tops and a uniform top that just says RN and the name of the hospital. So if Harvey Dent really had a burn like that in real life, he would be intubated, he'd be on a bunch of medications, receiving a ton of IV fluids. He would be really, really sick and really not able to fight back when the Joker comes. And here in the background, you see some coronal images, which is means a picture taken in this dimension of the body. That looks like an MRI slice of a brain. It looks pretty normal. I'm not sure why Harvey Dent would have needed to have had an MRI.
I don't want there to be any hard feelings between us, Harvey.
A patient intake survey, Parks and Rec.
Everything you write down is confidential. We need you to give real answers.
Fine.
So there are definitely some patients I meet that are not super trusting of doctors. It's okay, it usually comes from probably a bad experience, but there are better ways than what she's doing to sort of work around that and get the patient to warm up to you a little bit.
Ron, you redacted all the information.
I answered some of them.
For date of birth, you wrote springtime.
You should be a little more friendly. Her tone is a little terse. She looks a little impatient. Her facial features are not super friendly, warm, welcoming, or patient, so she could probably take a chill pill and try again. Organ procurement, RoboCop 2.
Make it fast, we've got 6 minutes before the brain's useless.
So I'm not sure what she's talking about. The brain is always gonna be useless. There's no such thing as a brain transplant. So this is the way Hollywood brain surgeons like to do craniectomies, which is like a full top skull cap craniectomy, but that's not really how it's done in real life. As far as I know, there's no suction cup effect, but correct me if I'm wrong.
Here it comes. Thing of beauty.
So this makes no sense at all. So this guy's supposed to be dead. This is a bypass machine. So the bypass machine is pumping blood for him in a supposedly dead body. So just not terribly consistent. I've never seen a dissection like that. I don't think you could get all those parts out together on block like that. I mean, to transplant organs, you just put them in a little bag with ice in a plastic bucket. You don't use this bubbling fish tank sort of setup. I've never seen that before.
We're only human.
A gunshot wound from Seraphim Falls. You don't necessarily need to remove a bullet just because you have a bullet inside, but if you want to have Pierce Brosnan take his shirt off and flex, this is a good excuse to do it. So you could definitely use a red hot metal blade to cauterize a wound, but that thing was not actively bleeding, so I would just have left that alone. Another shirtless guy using fire to cauterize his wound, Rambo 3. Here's another guy with limited medical resources and what appears to be a soft tissue injury. In the absence of, hemorrhage or something that really needs to be controlled, I would just leave these wounds alone. But I think this is pretty reasonable technique to cauterize, but again, completely unnecessary.
You're not serious. Oh yeah, I'm serious.
The janitor makes the diagnosis, the fugitive.
Al, get over here. I need you to fix the room. We got another head coming through. Hey, can you give us a hand here? Can you bring this kid down to observation room 2?
It would not be typical for someone from the housekeeping staff to transport a patient. This doctor/janitor is looking at the x-ray of what looks like a baby. You can tell sort of from the dimensions of the chest and the way the bones look. He's also looking at that x-ray backwards. You can tell because the heart is not where it's supposed to be.
Pull that elevator. Watch out.
How are you doing, kiddo?
Chester.
Yeah? Where's your mom, Pat?
Oh, no.
Is she home?
She's with my brother.
Your brother? They're downstairs?
Oh.
I can't exactly tell what he's crossing out and what he's about to write, but on any medical record, it would be really suspicious to cross something out. You'd have to get a new form.
They sent this one from downstairs.
So patient handoff doesn't really work like that these days. Usually it's a series of phone calls from the nurse in the ER to the accepting nurse in the OR on the floor. Same thing with the doctors. There's a series of what we call handoffs about the patient, what the diagnosis is, what workup has been done, what other tests still need to get done. It's usually not like this where it's kind of a word of mouth and a trust this guy in the janitorial uniform to give me this kid and this diagnosis. That's a little suspect.
Bye-bye, Jewel.
I don't typically affectionately rub the faces of my patients before they get wheeled off to surgery. No, that's not really my style. Horse tranquilizer straight to the neck. Old school.
What kind of gun is this?
That's a tranquilizer gun.
Ow! Not exactly sure what tranquilizer was in that tranquilizer dart, but one common tranquilizer that we might use in the emergency setting is something called ketamine.
Yes!
It is a drug that works very quickly. It doesn't cause any major hemodynamic shifts, meaning it won't alter your blood pressure too much. And it's a quick on, quick off kind of drug. So it's a pretty good medication to sedate a person in the emergency room if you have to do some quick procedures.
Wait, pull what out?
So definitely as the medication is setting in, patients will start to feel foggy, start to feel groggy, and may have some mental slowing.
Whoa.
Impersonating a doctor. Catch me if you can.
Gentlemen, what seems to be the problem?
Bicycle accident.
Sponge tick strikes again.
Fractured tibia about 5 inches below patella.
Dr. Harris.
Yes?
Do you concur?
I mean, he sort of looks like a doctor, he talks like a doctor. I think he could probably trick a couple people, but I think that this is a little bit of a stretch.
I think we should take an x-ray, then stitch him out and put him in a walking cast.
So I completely disagree with his suggestion to get this kid in a walking cast. What that looks like is called what we would call an open fracture, meaning you can see the bone through the injury. So that actually is pretty involved. It's usually more of a severe injury. That patient, you should probably go up to the operating room, get a really good washout for concern for infection, and probably get some surgery to fix that bone. A dead giveaway here is the nausea. Most doctors aren't too squeamish. Here's an example of a patient arrival in code black.
16-year-old boy fell downstairs, minor burns, no KO.
Hey, how you doing, buddy?
Fine, I fell. This is all probably overkill.
Did you see the incident, sir?
No, I didn't.
Anything else you can tell us?
Nothing.
So this is a pretty good example of the first responders doing what's called giving report. They are bringing the patient in, they're telling the doctors and nurses in the hospital what happened to the patient. It sounds like this patient fell down a set of stairs.
Minor burns, no KO.
When they say no KO, means no loss of consciousness or no knockout.
Anything else you can tell us?
So here we have two nurses sort of dividing and conquering. One nurse is getting what's called collateral history from the person who came into the hospital with the kid, and the other nurse is attending to the child's medical needs right now.
It's really dumb. Actually, I fell down some stairs.
This seems like a pretty stable patient with a relatively minor mechanism of injury, so for that reason there's no trauma team or a bunch of surgeons running around trying to figure out what happened to the kid. It's pretty much just nurses at this point. Tick-borne illness, House.
He has tick paralysis. Dan tracked a tick onto his jeans.
Tick bites don't ordinarily cause anaphylactic shock.
This girl's allergies are not ordinary. I'm administering atropine. This is just gonna get worse.
So that bag valve mask, that's like atrocious right there. Bag valve mask ventilation is seen here with this purple, that's called an ambu-bag, as well as that mask that's on the patient's face. That ambu-bag should be squeezed in a very particular way to observe the chest rise and at a certain rate. So the rate at which she is squeezing, which is really fast, that's gonna cause a couple things. Number one is hyperventilation. Number two, she's just gonna fill that patient's stomach with air, which can cause a lot of other problems down the road.
As long as we're stuck here, this might be a good time to look for that tick.
Atropine's wearing off.
So he says here that atropine is wearing off. Atropine is a medication that we would use for bradycardia, which is when the heart rate is really slow. So it sounds like she got really bradycardic. They gave her atropine. It's wearing off, meaning her heart is slowing down again. And on the monitor, you see that her heart rate is 45, so that's pretty slow.
We treat her symptoms, she dies. We find the cause, she lives. That tick is an IV drip of poison. We unhook it, she'll be fine.
Oh my God!
See?
Usually with tick-borne illness, you get like what's called a dilated cardiomyopathy, but that takes like weeks to months to develop. This is not real. I don't know what to tell you.
Conclusion.
I realize that a lot of what Hollywood does in the OR and the ER is for dramatic effect, but it's pretty fun to check out what they do right and what they do wrong. And don't forget, if you're enjoying technique critique, subscribe to Wired.